this chapter is kind of I don't want to say a pet peeve of mine, but believe it or not, I guess I'm kind of a medical, legal, ethical nerd. Uh, Part of one of my former jobs, I was the safety and risk coordinator along with the clinical and education manager for South Mississippi for AMR for a few years. And risk, safety, the legal aspect, quality assurance, compliance was something that I really enjoyed. And I didn't use it to at all try to get people in trouble or anything. But what surprised me the most was how much we were unaware of. Now, most, I went to EMT school a long, long time ago. It's like in the mid 80s. Some of you probably have only read about that time. And even then, and went to intermediate school years later, and even the critical care and flight program that I did, and the paramedic program, the medical legal aspects of it, a lot of times just pass over it. It's like, hey, here you go. They skim through it right quick. But this is to spend so little time on it. This is one of the areas that can have a big impact not only on your professional career, but your personal career too. It can really get in and get to your personal life as well sometimes. So this by no means is a substitute or legal advice or anything. It's just more or less kind of making you aware. And I want to like a little disclaimer of your your areas that you work in, your company that you work for usually already have a policy addressing a lot of these, or they tell you to address their own legal department or HR department, or even your protocols and procedures, which will cover a lot of that. So this is more or less to make you aware, and it's a general type lecture, which means that it's kind of broad based and covering a national scope. And we all know that each individual area can differ on that as well. I may give examples or things that I know pertaining to the way Mississippi does or Louisiana does, because that's where I'm most familiar with. And some of you in other areas, I'll ask for some input at that time if you're familiar with how something might work in the area that you're in. So the lecture tonight, emergency care, the prep, we're going to talk about some fundamentals tonight. Basically, your safety, well-being, what's going to keep you out of trouble, and some ethical and legal issues. Now, we don't want to base this on something like, well, I'm going to do just what I need to do to keep out of trouble. We don't want to treat according to that. We don't want you to treat or make decisions out of fear. So the bottom line is, and I gave this somebody that might not have been on a couple nights ago, and I do have the recording from that lecture. I just got to upload it into YouTube. I'll probably do that tonight or tomorrow as soon as Rob Roy gives me information. But if you're able to say why, if you use this philosophy in everything that you do, but especially EMS, it's worked for me for 34 years, is that be able to say why you do something or why you don't do something. If you can't say why, then you're going to have a hard time defending that decision. You're going to have a hard time for getting others to realize your perspective on that, but be able to say why. And this is an example of, hey, why didn't you, or why did you put this patient on a backboard and he didn't have a spinal injury? The why might be, well, I used that to carry him out of the house. So I mean, just be able to say why. Or why didn't you give this patient aspirin? He was clearly having chest pain. Well, he was allergic to aspirin. Well, like I said, be able to say why. And a lot of the other stuff will kind of sort itself out. Another standard that I've stood by is, hey, how would I want my family treated? Is this good enough for my family? So most of the time, if you do what's in the best interest of the patient and in good faith, that'll fall on jury's ears better than just like, well, man, I don't know why I did it. I just did it. Or I read it in a book, or I heard a news story, something like that. So we'll talk more about that as we go on. The some medical slash legal and ethics. Some of these are just some of the topics we're going to carry on. This point right here, we're not going to get real deep into it, but we're going to talk about consent, refusal of care, confidentiality, advanced directives, tort and criminal actions, evidence preservation, and statutory responsibilities. So this will be broke down a little bit more further on. We're going to talk about mandatory reporting, ethical principles versus moral obligations, end of life issues. All of these are things that really don't have to do with the technical medical care, but why you did not do what you did, and if what you did increased harm. So, a basic principle that we all learn from the beginning. The first rule of EMS or medicine is the first to do no harm. Do no harm. It's what I'm going to do this patient harm. If not knowing is one thing, but if you do something and you know that it might do harm or the possibility of doing harm, then that's something that's right. That question's answered for you right off the bat. So litigation involving EMS will no doubt increase due to the availability and complexity of emergency medical care. Now, you all are taking this advanced EMT class to get deeper into medical treatment, to provide more advanced skills. With that becomes more accountability. You're going to have more knowledge, more tools to use, and you're going to have to be able to justify and play on the indications of what's given to you by a patient. Because you're getting a higher level of care. More, it's going to be expected of you to know more. You're going to be held to a higher standard of responsibility than a first responder or another EMT. Now, some areas they're using advanced EMTs on the ambulances already, and they're the highest level of medic. I know along the coast is the company I work for is actively recruiting advanced EMTs. And, you got to ask yourself, if you're the highest level care person on scene, everybody's going to look to you. Hey, we called you to make a difference. What do you want the rest of us to do? And, that weight is pretty heavy. I could vouch for that. So you're going to be required to think about what's competent, what's doing the right thing for this patient. We're going to talk about there's a new set of laws that will govern you, a new set of regulations that will govern you as an advanced level provider. So the biggest thing to help protect you from this is to be competent, know your protocols, know what your standard of care is, know what your scope of practice is, and don't deviate from that. And we're going to talk about that a little bit more in depth, but that's how you kind of keep out of trouble. Be responsible. When you're setting on post or at the station, pull up the I know on the company that I work for, on our computer patient report, or some people have the tough book, some have another type, but the procedures and protocols, regulations are on that desktop. Pull it out and look at it. Look at ones over and over. But no matter how familiar you are with it, that's what they're going to what you're going to be tried against. We'll talk about ethical issues in a little bit. Ethicals are the principles, personal or societal, that they determine what's right or wrong. Can anybody tell me the difference between, let's say, an ethical issue, or an ethical requirement, or an ethical issue, and a legal issue? One example that I read about, I read a lot of case studies, and one of them was take a physician on an airplane. Somebody has a heart attack. Most of the time, legally, they're not required to get involved, but ethically, maybe they should. That's one example. Does anybody else might have something to comment on that? If you being, and it does deal with this a little bit later, but say like if you're off duty and you drive upon a car wreck, are you legally required to stop? I know for a fact in the state of Mississippi, if you're off duty, you are not required to stop. Legally, you're not required to. Ethically, that's up to you. So those are kind of some differences between that. You know, even though sometimes you do everything right, you do what you're supposed to do, there's still people out there that may want to try to sue you. So one of the big differences between laws and ethics is that laws have sanctions for violations that are enforceable. For example, laws define your obligations and protect your rights and rights of others. Failure to perform your job within the law can result in civil or even criminal liability. Civil has to do with you being sued monetarily. Criminal means something you can go to jail for. So another one is practicing outside the law may result in regulatory action within your state. You could let's say you stop on the scene of an accident. You're an EMT, and the patient has a let's say a tension pneumo, and you know what needs to be done, but decompressing a chest would be outside your scope. And if you did that, then you can get in trouble from your state by it. Now, and that's something you could even go to jail for, lose your license for, even though you might have saved the person's life. It is outside your scope to do that, and that is legally punishable. But
I think when you talking about ethics, hey, sorry to interrupt you. I just want you're talking about ethics and stuff. That's majority of the things that I think about is knowing what needs to be done, but understanding that you're not allowed to perform something. So it goes both ways. If I come across an accident, do I have to help? No, I don't. But I'm not going to be criminally charged or really nothing's going to happen to me if I don't want to help or if I just don't feel comfortable.
yeah.
But there's also, another side of that where you may want to help and you may, just as well know, taking like the PHTLS class, how to do a chest decompression. And then you do it. Well, now you violated, you didn't violate your ethics, but you violated the law. So you have to make a calculated risk, on what you want to do there and what it's worth to you,
And a point on that is breaking the law ethical?
I think it depends on the scenario. If I'm just CPR certified and I saw in Grey's Anatomy someone do like an emergency tracheotomy with a pin, and it's like I'm just gonna try it because I saw it on TV. It's like, well, I might be able to help, and then I slice the throat and kill them, And
then you're grossly negligent and going to jail.
Exactly. I think that's the difference, is understanding your own. It would be unethical and illegal if you knew that you did not know how to perform that and you tried it anyway.
Yeah. And we'll see that term later, is if you do something and it causes harm, or if you take on something that is outside your scope, then your ethics may or may not keep you out of jail, but breaking the law, definitely can get you put in there. There's and there again, that's doing the right thing. And that's when I ask people, well, you're knowingly breaking the law. Is that ethical to break the law? So that those are things that if they go to court, a lot of it is based on how you can convince the jury or not. So right now, this is just some things to think about, and these are just some subjects that I'm going to touch on a little bit different, a little bit more. So even if you properly render emergency medical care, at times you may be sued by a patient who seeks to obtain relief, usually in the form of a monetary award, and they might can do it for loss of income, pain, suffering. Maybe administrative action taken against you, is like suspension, or some people being terminated. I've seen physicians pull medical control from medics before in the past, and because they did not want this person functioning on their license anymore, even though, hey, like for example, this one scenario was man was having a stroke, and no, I'm sorry, back up. This is another. Man was having severe chest pain, and he had taken Viagra like 6 hours before they gave nitro. Don't you give nitro for chest pain?
Can.
And
not after Viagra.
exactly right. So, and the medic was, he was like, yeah, but he said, aside from the Viagra, he said, I wasn't worried about the Viagra. I was worried about taking care of the chest pain. So they gave the nitro, which was, hey, that was, that was negligence because it can do wrong. And the fact that he did wrong. And why the reason he got his medical control pulled was because the guy says, well, in the same situation, I'd do it again. So, that is, ethically, the guy thought he was doing right. He really believed in his power and he was doing right. However, legally, he was not, because he was negligent. What he did caused harm. It caused the patient to become profoundly hypotensive, but what he did caused harm. So, and this will make a little bit more sense to you as we get further on. Scope of practice. This outlines the care that you're able to provide to somebody. State law usually determines this. National registry sets like some standards and techniques and skills. Like, for example, on the national curriculum, EMTs are taught to put down advanced airways, because some places allow EMTs to do like the Kings and the combi tubes, PTLs, things like that. However, the scope of practice in that state may say no, they are not able to do that. For example, as I flew with Rescue 9 for almost 3 years. And then I was licensed in the state of Louisiana, Florida, and Mississippi. In the state of Louisiana and Florida, I'm able to do a chest tube on the side of the road if I have to. In the state of Mississippi, I am not. It has to be an RN that has been through their trauma program, or a Mississippi certified critical care paramedic can do that. So I don't look at, it was outside my scope in Mississippi, but not in Louisiana and Florida. And unfortunately, Mississippi has their own critical care paramedic program, and unless you participate in theirs, you're not able to function under it. What's odd is that they have to take the FBC test, which I already have, but I was told, well, you don't have to take the test, but you just got to sit through the class, which is kind of crazy, but that's beside this point. But in a minute, we'll break down protocols along with standing orders and scope of practice a little bit better for you. So the break it down even further. You'll have protocols, standing orders, which is made by the medical director, your company, which will work together. Standing orders are what you can do without having to call for an order. Now, the way I understand it, I see if some of you I've met before. I think most of you that's on tonight, and I'm not by any means, don't let me think I'm just counting anybody else if I talk about just one particular area that I'm familiar with. But I know that on the Gulf Coast, they have a new protocol in place that allows their advanced EMTs to function to a certain level. Now, it may say under their standing orders, they don't have to call to start an IV, or they don't have to call to do this or that. But in the protocols, they might have that which contain the standing orders, but it might get to a point to where it says call for medical direction or consult med control. So protocols are things that are, a better word for it is guidelines, which don't say that you absolutely have to to be a textbook or a cookie cutter advanced EMT to where it's like, well, I can't think, I just got to do this. Well, that's not what it's there for. It is a guideline. At this point, consider this, or at this point, consider this. That's what those are for. But standing orders, let's say, for example, you are in your scope to put down a King airway. A standing order would be in case of respiratory arrest, cardiac arrest, it's a standing order for you to go ahead and put down a King Airway. Things that you need that you can do without having to call for it. Your medical director, you work under their license. They have authorization to provide care relayed to you. You're functioning underneath their umbrella. You have online medical control, which is usually somebody that you're going to call at that time, whether it be via radio or a telephone. Your online medical control is who you would talk to. Some services I worked for, our online medical control would be the service that we're transporting to. The service that I work for now, we have kind of a central medical control. It doesn't matter where we're transporting to. We consult that facility. They do have a couple of alternate facilities, but that's who we call actually to talk with them. It's kind of like I have something that I need to do that's outside my standing orders. It may be in my protocol or maybe in my scope, but I need to ask for it. Say like if like where I work, we can give up to 2 milligrams of Dilaudid without having to call for any more. But once I reach that, let's say I'm coming from Picayune going all the way to Hattiesburg, that Dilaudid's going to wear off. But my max by standing order is 2 milligrams. So let's say I get halfway and the patient starts having pain again, then that's when I might need to call. Say, hey doc, I've given him 2 milligrams of Dilaudid. His pain level has returned. I still have 30 minutes to go in this transport. I would like consideration to go ahead and give him another dose. That's online medical control. Offline medical control is usually the medical director who writes the protocols, the standing orders. That's someone who you don't talk to every day, but you still operate under their license. Fortunately, most of the places that I've worked have been pretty liberal with their standing orders and protocols to where you didn't have to call that often. But let's say, hey, let's say you're an advanced EMT, which they're returning back to this level of EMT, and it's pretty new to a lot of people. You can ask a lot of people right now around, senior medics that's been around a while, hey, what can an AMT going to do? Can do, and they're going like, hell, I don't know. And it may cross over to you, hey, I'm not sure about this, and that's when you like, hey, you would call medical control. Let's say you're coming from Picayune and you're going to Hattiesburg, and let's say Sarah's on that truck. She's got this patient in the back, and they're hypotensive, and the standing order said that you can go ahead and give 250 cc's of saline to try to get the blood pressure. Let's say you repeat that twice. Well, let's say she's done it twice and she needs to do it again because heck, it's almost an hour ride. And that's when she would call and said, hey, call the medical control hospital and said, hey, I've given the 2 standard boluses. However, we're still a little hypotensive. I'd like to go ahead and give some more. So that's simply what that would work for. Is you want to call and get some extra advice, or it's like, hey doc, here, I know what my standing order says. However, I'd like to discuss something with you. You got something that doesn't really fit what's in the book or in front of you, the standards, and I've been doing this a long time, and I still will call a doctor and say, hey man, here's what I got, here's what I've done, but I'd like to run something by you and see what you think. And if you got to get an order for it, it don't have to be exactly in your protocol. It still has to be in your scope, but it really doesn't have to be in your protocols if a physician authorizes it, but it's still in your scope. So never be afraid. In fact, I encourage you to call and discuss things with your medical director or online medical control sometime. Now, carrying out procedures which an EMT is not authorized to do is some things what that would be considered. Let's say you can start IV fluids, but it can't contain any drugs. But let's say you go ahead and start one that has lidocaine in it. Let's say that you didn't realize it until you got to the hospital and you'd hooked up. There's an IV. A lot of companies carry these already pre-mixed IV medications in the same size bag that your regular fluids are in. They really shouldn't be kept with regular fluids. Should be kept somewhere else, like in another medication box or anything for this. But you get to the hospital and you look up and the writing on that bag is red. It says lidocaine and it says 1 gram and 250. Now you've given that. That's negligence. Why would it be negligence? Did you mean to do it? Might not have, but did you omit some steps? And as we'll learn as we go through this, well, I didn't check what it was. You'll learn about the 5 rights. The right patient, the right fluid, right medication at the right time, at the right route. So that that can be considered negligence. And let's say if that patient had an allergic reaction to that, or let's say they had a heart block that you didn't know about, and it killed them. Now you might be looking at criminal activity because your action killed that patient. So those are some things that could fall under there, and that's because they went outside their scope and gave a medication, whether they meant to or not. It did happen. So all your patients should be treated in a professional manner. And think about the way you'd want your family treated. We've all worked those long 24-hour shifts or longer in some cases, which can be dangerous. Some people can handle it, but I choose not to do those anymore. But let's say you're on your you hadn't been to the station in 16 hours and you get a call for this little old grandma that's having bad stomach pain. She's been having it for 2 days, and it's aggravating. It's not where you want to be at right now. I know that. Been there. But what keeps me from blowing up is I go back and I think about, how would I want my grandmother to be treated? Because to them, you might have had 18 calls already. This might be one of the most significant events, in her life. Who knows what what could really be, but that's when we got to think about treat your patients, try to bring these situations under control, think about what you'd want done to your family. I've had to do that many times and still do today sometimes. You got don't confuse scope of practice with standard of care, and we'll break that down a little bit more. But you and other EMS providers, you got a legal responsibility to provide proper and consistent patient care, report problems to your medical director immediately. When you have something go wrong, report it. Don't try to hide it. A lot of times trying to hide something can be punitive, punishable, and sometimes mistakes, it could go either way, but it could go worse if you try to hide something. I had a medic call me once and said, "Hey man, I let my EMT partner, is a patient that, how many of you have been on scene when you have to give D50 and wake these people up, wake a diabetic up? It's pretty amazing, and it's really kind of routine. You start the IV, you do the blood sugar, it's low, you start the IV, and you put together the amp of D50, and you push it, and they wake up. An amp of D50 is really it's a pretty good size syringe, right? It's 50 milliliters. If I ain't mistaken, or it might be 40. It's a pretty big syringe. Well, this medic called me after the call. He said, "Hey, man," he said, "I made a mistake." He said, "Here's what happened." He says, "My partner handed me the syringe and I pushed it. And when I got back out to the truck, the patient didn't wake up right away." He said, "So I went to open another one and I saw the empty sodium bicarb box." Both of these syringes are pretty much the same size. And you can see how easily it would be if they both were unmarked. So what did that medic do? First off, he didn't check it. He didn't verify it. He let somebody that wasn't trained to do it technically put it together and give to him. But he did call right away. And he did call right away, report that. We talked to the doc. Really, no harm done. However, it could have been something bad. But the big thing is when something like that happens, report it. Report it right away. A standard of care, when we talk about standards, that's an acceptable and expected way to behave. It's, you have standards in society that you follow. You have standards like let's say if you're going to date somebody, you have standards which this person's got to meet, So standards are an accepted way of behavior, accepted performance, appearance. All that goes under what the standard of care is. So the law requires that you behave toward other people in a certain definable way, regardless of the activity involved. Now, when you're being paid to be an advanced EMT out on the street, you're under a professional expectation of standard of care. The law requires really how you're going to act and behave. Under certain circumstances, you may or may not have a legal duty to act or not. Seems like my computer's giving me some problems again, so just bear with me here. Looks like my PowerPoint went away.
Job security for the IT field.
Yeah, I don't know if it's me, maybe my system, man. I got rid of using that. That was, I don't know how those people stay in business, and I went to this AT&T, and today's really the first day I've had any issues with it. Okay. A legal duty to act or not. We talked about that a little bit earlier, but generally, you must be concerned about the safety and welfare of others when your behavior or activities have the potential to cause injury or harm. Now, when you arrive on scene on a call, you are the authority. A lot of times the answer prayer is somebody that's having a crisis. So certain expectations about your behavior is expected. So what you say or do is actually a potential to cause injury or harm. You walk in and say, "My God, what's up with your face?" That's you're talking about anywhere from self-esteem, making them feel bad, or actual physical injury. So you're also kind of responsible to what some first responders or other personnel there are on scene if you're the highest level caretaker. So a baseline definition of that is the manner in which you are required to act is called the standard of care. Medical research a lot of times establishes how you're supposed to act or standard of care. Like we know that a patient that's short of breath needs oxygen. A person with this type of training would be competent and know that this person needs to be put on oxygen. Local customs. What do we mean by local customs? It's kind of like someone that has the same training that you do with the same experience, the same type of equipment, and under the same circumstances. How would they act? If you work 72 hours straight, let's say the whole system works 72 hours straight, and you're fatigued, you're tired, you haven't eaten, you haven't bathed, and you smell bad because you've been running 3 calls in an hour. The customer calls in and says, "Hey, that paramedic or EMT smelled real bad." Well, if you think about it, how's these other people smell and look, being up 72 hours, hadn't ate, hadn't bathed, and stuff like that? So that would kind of fall under what somebody would act like under similar circumstances. It's not a real great example. It's just kind of taking some of the medical part out of it without you getting bogged down in the medical aspect of it. That can actually apply just about anything that you do. Based on locally accepted protocols. I've
got probably a good example if you want it.
Yes.
So a good example of a standard of care would be, let's say put yourself in a paramedic's shoes. You show up to a cardiac call, and like Lynn said, you've been at it for 71 hours of a 72-hour shift, and you're exhausted. You've run cardiac calls for the last 2 days straight, whatever, and you're over it, right? So you get this guy, he's in your truck, and you have to run a 12 lead. But you don't want to run a 12 lead. You're exhausted. That's just too many leads. Don't want to deal with it. You hook up a 4 lead, you see something, and you make your decisions from that. That being said, was that enough? Should you have really skirted your ability or your responsibility to run a 12 lead and get a better view of the heart? That would be an example of you losing your standard of care.
Yep.
You were in your scope of practice. Whatever you did was perfectly fine for what your level of training was, but then you do it to the best of your ability and to the standard that is set forth by the state, by the National Registry, and really should be set forth by your own ethics and morals on what you're supposed to be doing.
And that is a good example. And there again, we need to think about if those type of conditions are not allowing us to do standard of care, or what's standard of care, then there's a big system issue that needs to be worked on. That still doesn't mean you can't be sued for it. Because let's say failure to find a STEMI resulted in somebody's death or something. And there again, I'm not picking on any one company. I'm just trying to give some examples right now because the law is not always black and white. So when it talks about local customs, example, let's say you work in an area, a rural area, and they've got 2 hospitals. Both hospitals might be a stroke center. Both hospitals might have CT scans. But in that local area, it's understood that Hospital A has the in-house CT person, whereas Hospital B might have to call somebody in. I mean, both hospitals might be appropriately able to take care of that patient, but based on that local information, that would be something like, well, everybody here takes the patient to Hospital A because they can be seen much more rapidly than at the other one. So that's something what kind of would be done with the local standard of care. Say like I work a lot of different areas. Sometimes I'll go to Macomb or Picayune or something like that. The first thing I ask is like, okay, which hospital do y'all go to for this or go to for that? And those medics in that area have pretty much know, hey, in this situation, here's where we go because, here's why. So that's kind of like what goes on in that area. What is the standard for this area? So, does anybody have any confusion in that part about standard of care? I've been on a witness stand before as an expert witness and as a witness and to give depositions. And I've seen it to where when one paramedic might be, and it's usually not with the same company because then the local things come into play. But for example, I've worked for some nationwide companies and been given a questionnaire or asked questions about a scenario. And they would say like, they wouldn't tell us what happened, but they'd give us a scenario. They'd give like 10 paramedics this scenario and see how that they would operate, see how they would function with it. And if most of them, the majority of them did things a certain way, and the person in question did it totally opposite, then you could actually see where, hey, they're not meeting the standard of care. Let's find out what's wrong with it. But that's in a court of law, they will actually sometimes call in expert witnesses and ask them, and you may have seen it on TV, what would you have done in this situation? In many states, treatment protocols will kind of guide the standard of care. Have any of you ever heard of the EMTALA Act? Or that is the way it stands for is Emergency Medical Treatment and Active Labor Act. It should be on the wall of every emergency room that accepts Medicaid, Medicare patients in the United States. It's supposed to be to where they can see it. Now, the reason this was put out is most of you probably weren't around in the EMS back in the early 80s and stuff like that. But the reason this was put out was to stop patient dumping. I mean, clearly denying treatment for somebody for one reason or another. You know, it occurs when a hospital department staff may deny medical screening or stabilizing treatment, or when the staff inappropriately transfers a person whose condition is unstable. It actually was to stop patient dumping. And this is anyone that shows up at the hospital. And now that if you can see under these on these postings in the ER, it talks about someone who comes with a medical emergency or in labor has the right to receive stabilizing treatment and or an appropriate transfer for that treatment, but they have to be so much as stabilized first. You can't just send them off. They can't refuse to see people. It also has to do with there used to be a lot of economic triaging going on. I've actually worked in cities to where people with no insurance went to one hospital, and people with insurance, that was a question that we asked. If they had insurance, then they had their choice. But if they didn't have that insurance, then they would have to go to the charity hospital. So this has done away with that. They call it economic triaging. So, and it was based on the healthcare decisions were based on the ability of the patient or the insurance carrier to provide payment for the services. So, you know, we can't make a decision now to treat or transport a patient based on financial consideration. I don't ask anybody anything like that. I don't. I've seen, I've actually been in a room when one physician called another hospital and says, "Hey, this patient has such and such. They got great insurance." That right there is a law. He just broke a law. He broke a federal law by doing that. I know of one physician who said that when he got a face sheet or information, he did not want any of that information on it because he didn't want to be accused of being biased in any way. So, and it also causes to have a clear understanding of the local protocols regarding the choice of hospitals which you may transfer your patient. You know, I work in Hattiesburg. I like working in Hattiesburg. They got two choices. I don't like areas where, I don't want to say don't like areas, but I'd rather not. And I've been to areas before when they have 8 hospitals available. You know, where do you want to go? Okay. And then hospital A gripes about, "Hey, why did you come here? We're not the closest." Hospital B is like, "Why did you come here? We're not the closest. Why are you bringing them here?" You know, you get a lot of that. You know, in Tyler, really, they're really breaking the law by doing that. But that's one reason I like working where I do. I've had patients in south part of Pearl River County, you know, they want to go 70 miles away to the other side of New Orleans. And you know, it's kind of like, "Hey, that's the only hospital I can go to." And I'm like, "Well, you really should have thought about it before you moved here." But that happens in a lot of those areas. And that's just it's a form of stress on the medics, really. So EMTALA guarantees a medical screening, exam, and treatment to stabilize emergency medical conditions found to any patient presenting to the hospital that has an emergency department. You know, if they don't have an emergency department, a recognized emergency room, they don't fall under EMTALA. But if they do, regardless of who or where they are obligated to fall under this. You know, EMTALA it's regulated by what they call the Centers for Medicare and Medicaid Services, or another term you may have heard is CMS. And it carries severe monetary penalties for hospitals that fail to comply with this. It also regulates transfers and applies to both the sending and receiving facilities. Now, remember this one, and I'm not going to say when it happens, but the fact that it will happen is that do not, you know, you're a new AEMT, and you're at the hospital to pick up a transfer. Do not transfer a patient who needs emergency medical care that falls outside your scope of practice. That is something that cannot happen. And there's been major lawsuits happen because of it. And I've actually seen, hey, that, for example, they did in certain areas, like a paramedic could not transport a patient that was on continuous sedation, like propofol. and the patient needed to be on propofol because that's what helped them keep intubated. And what the hospital would do a lot of time was give them a bolus and say, all right, in a hurry, and the ambulance try to go priority 1 across town to get to this other hospital before the patient wakes up. Takes about 20 minutes. You know, traffic conditions never go the way we want. That patient wakes up and pulls a tube out. Not only is the hospital in trouble, but you can be in trouble for accepting that. You'll be able to, as an AMT, you'll be able to transport patients that has IV transfers. Now, it is the hospital's obligation. Let's say if that patient is on blood when you get there, as an AEMT, you're not going to be able to transport blood. And they DC that blood, say, well, just hurry up and get there. You know, that is something you need to call your medical director about or your supervisor, because, you just took a patient that requires more than what you're able to give. It is mainly the hospital's responsibility, but the case studies that I have seen has it seems like the EMT or the paramedic has got caught up in it. One example is in the state of Florida about 8 years ago. One hospital was sending out this lady that was in premature labor, had a high risk pregnancy. The EMS service accepted the transfer, so did the receiving facility. Well, when the baby was born en route between the two hospitals, this baby required a neonate team. It had needs that the paramedic was not able to give. Well, it turned out that the baby died and the family sued big time, both hospitals and the EMS service. Well, the two hospitals settled. The ambulance service tried to fight it, and they lost to the tune of about $6 million. The paramedic was cited for getting out of his scope because he accepted a transfer that somebody required things what he was beyond what he was able to provide. So anytime you get something that you're not uncomfortable, and I'm talking about something that you can't say why you're doing, or you get that uneasy feeling, you need to make a phone call, because you can get in serious trouble by transporting something that requires outside your scope. If they try to send you with something that's going on still that the patient needs outside your scope, you really need to turn it down. A patient has an IV, but hey, they also have a chest tube. Don't take that patient. That needs to be done by a paramedic level or higher. And some places may try to force you to do it, saying, hey, you're the only one that's available. It's going to take forever for another truck to get here. That is a situation you don't want to be in. So also, before you leave, make sure, transfers is not something that that a lot of people don't like to do. I don't mind them myself. To me, I take it as a learning opportunity to learn about different conditions. But you are a continuum of care with that transfer. You need to make sure that you've received all the appropriate paperwork before leaving, the COBRA form, medical records. They might have CDs in there, but make sure you have that information and goes with you, especially the COBRA form when you get to the other facility. Because I've got, that call. Let's say if they call that transfer in at 5:30, and you get to the other place at 7:30, they've made crew change, and I'm sure all of you that's been doing this any length of time have heard, well, I know nothing about this patient. Nobody called and told me anything. So you see how that goes. So be sure you have that. You said, yes, they did. So and so accepted this patient at this amount of time. And I've been on that end to where it seems like everybody just plays ignorant to the fact.
You said, what was that form you just said? COBRA form?
Yeah, there's one that says COBRA form. Some people may call it different things, but what it looks like is it should have the patient's name, of course, their diagnosis, and the receiving facility with a receiving physician listed on it. Kind of look for that.
Okay.
Yeah, kind of look for that. Make sure it has the signature dissenting and like what their diagnosis is and what they're going for. And that's I got two.
Is that similar to the face sheet?
No, the face sheet mainly has demographics on it. Name, date of birth, address, insurance information, and the COBRA sheet or the CMS form is what we get when we look at it. It usually has a patient's name, their diagnosis, the facility they're being referred to, and it has to have a receiving or an accepting physician on there. And it also may have down at the bottom, patient requires monitoring or IV fluid, stuff like that. That's the one that you need to have. It makes sure it has an accepting physician with a name on there. It may have like a PCC or transfer coordinator's name, but you need to make sure you have that. That means that the transfer has been initiated and accepted, and you're providing the transport of that. So, and that's when they get on the other side, that's a legal binding document. They can't say, why did you come here? Why did you do that? Hey, it's been arranged. And to show you how important that is just about 1 month ago, I took a patient up to Jackson, and it's a burn patient, and it was supposed to be a direct admit to a room. Well, when I get there, there are like 8 ambulances on the wall, and everybody's been waiting. One ambulance had been there for 4 hours. My pain medicine had already wore off from him, and I'm like, well, it's a direct admit. I got a room. So they said, yeah, come on, you can go straight upstairs. So I went to the patient's room, and they says, oh, I'm sorry, somebody brought another patient in, and that room has been given away. You're gonna have to go back down to the ER and have him readmitted. I went, I knew better. I got the house supervisor involved, but and I got my administration involved, and it come down to my company saying, hey, you are in violation of a COBRA transfer. It plainly says you've accepted the patient. We got it on the paperwork. If anything, bump the other guy out. But they were trying to break a couple of laws, send that patient back to the ER to be readmitted as a patient, even though they've been at the other facility for 6 hours and being transferred up there. So that paperwork is the documentation that you need to kind of like to stand your ground on. It's not, I wasn't acting as a manager or a supervisor at that point, so I got my management involved. But I knew better to no, I'm not moving. I'm not going back to the ER, but I'll call my boss. And it was resolved very, very quickly when he started talking about, look, I've got a COBRA transfer. It's signed. That's that patient's room. So, and that was a legal sealed document, so to speak. So that paperwork means a lot. And I realize that some of you may not be real familiar with that hadn't been in the back of the truck, but that's what you're getting to be. And then a lot of times the advanced EMT trucks, may or may not be the one doing a lot of the transfers. So that's just something to think about. But that paperwork is everything. Learn to read it. I'll try to get you some examples. I can't show patient information, but it's some stuff to look for. But a lot of this stuff is procedural, and I know this chapter is not the most exciting as getting into the physiological stuff. However, as I said earlier, this is the stuff that can get you in a bind if you're not careful. So don't let this alarm you. This is why we're taking the classes, to learn how to do the right thing. Standards of care, when we talk about professional or institutional standards, like, for example, your CPR card, your CPR class that you've taken, that's a standard of care. That's what's expected. And if you go wrong from that or variate from it, then you can look at getting in trouble. But that is a standard. Some of these institutional agencies, like PHTLS, AHA, here's the standard that you need to follow. Get outside that, you might be in trouble. But that is, you're already used to a lot of standards. Your EMT program, and as I said last night, I try not to say basic EMT. I say EMT because you are emergency medical technicians. We no longer use the term basic. So as an EMT, you already have been following standards of care, and maybe you did or did not realize it. So you're already, you're in the middle phase now. When you get through this, you'll be 2/3 of the way of being a paramedic. So you're already used to a lot of this stuff. Maybe just bring it to light. The ambulance services, EMS agencies, your state Department of Health, these are the ones that usually set forward the standards of this, mainly in paper to start off with. This is a baseline for everything. Now, this is usually the minimum. You can add more to it or make more stringent standard of cares, but usually what's put forth as far as what the state rolls out is pretty much the baseline of what you got to go to. It's the ordinary minimum. But remember, if you act reasonably according to the standard practices you may have been trained to use, you have a good chance of avoiding liability. But just remember, anybody can always come back on you. But when you can go back and say, sir, this is why I did what I did, because based on these protocols or these standards, here's why I did it. And that's what I stand on. The state regulations can vary from state to state. Some of you that may live on a state line or work in another state than what you normally do, or I know some people that's got 2 states that they work in. I've got 3 state licenses. I've got to keep up with what the standards are in those things. Now, we don't cover each state standard or each state scope of practice in this, and I tell people those are available usually on your state websites. And that, I encourage you, each one of you to, you should have already been doing that. Get on there to find out what your scope and everything is, because we don't get into a lot of legal advice in this class, because that is outside our scope. We can just make you aware of what's going on and follow the best standard of care. Did I back up? A lot of your standards have already been imposed by, like textbooks, the CPR class that we talked about. The National Highway Safety Transportation Act, that was the first one that set a standard of care that is to be followed by EMTs. Legislation made by the state. Most states now have what is called Ems Enabling Legislation. It defines how EMS is structured and designates responsibilities to government agencies. These laws provide a state-based framework for EMTs. Now, I don't want to be said that I was saying anything about states, but put it this way: some allow people to do things, EMTs to do things more than others. Some states are easier to deal with than others, and Robert is the administrator of the class, and he's doing a lot of research behind the scenes right now to try to get that information ironed out for you and to you about what we can do in some places and not in others. But just be advised, if you go back and forth between states, that some do not act as quick or as liberal as others do. So that being said, some states, they're pretty much responsible for what they call the Medical Practices Act, and that is the practice of medicine is defined as the diagnosis and treatment of disease and illnesses. Now, I know we're not supposed to do technically diagnosing in the field, but there is a term that they're starting to use in paramedic classes, and maybe brought up in this class some, but I know he's in PHLS and things like that, and AMLS. But you got to have what they call a field diagnosis, or maybe a better term that is would be more appropriate to some, is you got to have a field impression. In other words, you got to have an idea of what's going on. I think this patient may be having this, or this patient this might be what's going on with this patient. You got to have a good idea. You can't make a definite confirmation. However, if a patient has an arrow sticking through his head, you can be pretty sure the patient's got brain damage, right? So you got to have a good idea of what's going on with that. That's what we call like a field diagnosis or field impression. So in some states, EMS personnel are exempt from the licensure requirement of the Medical Practices Act. Now, I did say in some states, this next sentence, because to me, I find this next sentence offensive, but it says because an advanced EMT in some states is regarded as a non-medical professional. And so is EMT in some states is considered a non-medical professional. You're considered a transportation technician. That's one reason the Department of CMS, even for the paramedics, they don't really consider EMS transport a medical institution, but a transport institution. Hence the low reimbursement, low wages compared to nurses. That's kind of where all that's tied up at. So, but there again, I consider you to be professionals. It's just sometimes the technicalities and these deep-bedded laws that were made years ago before they had all this training have not been addressed since then. So this act defines the minimum qualifications of those who may perform various health services. It defines the skills that each type of practitioner is legally and permitted to use, and it establishes a means of licensure. When you're unsure of the proper care or orders, you need to contact medical control. Question orders that are unclear or don't seem right to you. Hey, I questioned an order one time where verapamil is a calcium channel blocker, and it can cause an abrupt lowering of blood pressure. I had this 6-year-old kid that was an SBT. Heart rate was beating almost 200 times a minute, and his blood pressure was barely palpable. And the doctor told me to give him verapamil. Now, what's the side effect of verapamil? Lowering blood pressure. Doc told me to give it. I already had a low blood pressure. So if I did question that order. I said, Doc, you did say to give this patient 0.1 of verapamil with a pressure of this. He's like, correction on that. I meant adenosine. So if something doesn't sound right, you question it, repeat it back, because verapamil would have killed that kid. He would have gotten in trouble, and I would have gotten in trouble for committing the act for him. So things like that, that's when you would repeat it back and question it and ask for guidance on it. So don't blindly follow an order that doesn't make sense to you. Repeat it back, question it, and say, hey, just to make sure, here's what I want to clarify. Y'all have learned about Epipens, what epinephrine can do. It raises heart rate. It increases vasoconstriction, increases blood pressure. In a lot of elderly patients 55 or above that has a cardiac history, epinephrine is contraindicated without a medical order. You might have a standing order to give an EpiPen to anybody with allergic reaction up to the age of 55, and it requires an order. So I had a lady one time, she was in full-blown anaphylaxis. Her heart rate was about 160. And I knew she needed epinephrine, but I had to call it, run it by the physician. And he said, okay, he said, give 0.5 of Epi sub or IM and then 50 of Benadryl and then go from there. And I said, okay, doc, you did state, I have a 55-year age female, and you did state to give 0.5 of Epi IM. He said, yeah. He said, but look at where we are. Do we let her die from her anaphylaxis, or does she die from the Epi? He said, it won't be from the anaphylaxis. Either way, she might die if we do, but she's going to for sure die if we don't. So that's, another time I run it by him just to make sure we were on the same page with it, even though we both knew that's what she meant. Certification versus licensure. Certification is a process by which an individual, institution, or program is evaluated and recognized as meeting certain predetermined standards to ensure safe and ethical patient care. For example, National Registry, the NREMT, is a certification. It means that you have passed the criteria, the program that's set forth, you've passed it, and you've been deemed competent in understanding this. National Registry doesn't give you permission to do it. A license gives you permission to carry it out. Now, I know some people say, well, y'all are certified, but if you're in Louisiana, if you look at it, it says license. In Mississippi, it does say so-and-so is certified as a paramedic, but the state saying you can do so, technically that is a license, because it says that a license is the process by which a competent authority, usually the state, grants permission to practice a job, trade, or profession. So if the government that allows you to do it, that is considered licensure. Now, I've heard this argument go back and forth for years. Well, certificate versus license, blah, blah, blah. And I'm like, okay, let's talk about a nurse practitioner, or a nurse anesthetist. It says certified registered nurse. Okay, it says, and then so-and-so is a certified nurse practitioner. They do have a license to perform, but the certificate or diploma part that says, hey, they've completed that information is still considered a certificate. So don't let somebody try to insult you otherwise by doing that. Now, like certification is granted by a private organization such as the American Heart Association. It certifies that you have successfully completed a CPR class or an ACLS class. It doesn't actually give you the permission to go out and do it, but it does certify that you do it. Your license says that you can function as an advanced EMT, but your employer requires that, and in order to be NREMT certified, it does say that you also have to know how to do CPR. So that's kind of the way the certifications play in the progress. What you're licensed for in one state may not be granted in another automatically. That's why each state usually requires you to have their own licenses, and some will recognize what the other state has accepted as grounds to give you their license, and that's what we call, reciprocity. So, and a lot of companies actually require you to be certified in certain areas to actually be able to get a job there. So let's talk about negligence for a little bit. Negligence is the failure to provide the same care that a person with similar training would provide in the same or similar situation. A deviation from the accepted care that may result in injury to the patient. Now, that can be something that is done or not done, something you've failed to do, and it may have not been intentional. You just simply did not complete it, and that caused harm to the patient. Now, gross negligence, that's conduct that constitutes a willful or reckless disregard for a duty or standard of care. Like, hey man, this guy needs, he's bleeding. He needs pressure control. I'm not doing it. I don't care. I'm just not doing it. I'm just not doing it. That gross negligence. That was willful disregard for something that needed to be done, and a patient suffered harm from it. Negligence is broken up into three different categories. Malfeasance. That's if you perform an act that you are not authorized to do, such as we're talking about medical interventions outside your scope of practice. Like if you're an EMT and you start an IV on somebody, that's malfeasance. That's actually negligence because you performed outside your scope of practice. And or, for example, if you perform an act you're legally to do, but you do so in an improper manner. You put the oral airway in wrong. I mean, that's malfeasance. Nonfeasance, that's when you fail to perform an act that you're required or expected to perform. The patient needed to be on oxygen and you didn't do it because you didn't feel like busting a cabinet and having to recount the inventory to put another seal on. That's nonfeasance. It's something happened because you didn't do what you're supposed to. Now, this next one is I'm not sure how to pronounce it, to tell you the truth. I don't want to try, but it means the thing speaks for itself. This injury could have only been caused by negligence. Was nothing. There's not a lot of other information pointing to it other than, hey, because of what this medic did, this is what happened. Starting an IV without making a sterile field first, then they get a bad infection. It probably wasn't willful, but it is considered negligence because you really were negligent in trying to perform the sterile technique. In rare cases, the theory of negligence may be used if the conduct of the person being sued is alleged to have occurred in clear violation of a statute. For example, an AEMT performs a paramedic skill. A legal action of this sort is called a civil lawsuit, and that's usually instituted by a private person or entity against another private person or entity, the defendant. And that's when they want money from it. The wrongful act that gives rise to a civil suit is called a tort. The definition of tort is simply a wrongful act, and it leads to a civil liability. Tort is something you can be sued for. It means somebody's trying to get money. That's a wrongful act that can cause injury to another person. It's grounds for lawsuits, for compensation to a grieving party, or for any damages or injuries that suffered. For example, a car wreck where one driver hurts another driver because he was on his cell phone. That is could be tort. He can be sued for that and get money for the damages. Negligence is a tort. It involves harm caused by failing to act as a form of carelessness, not applying a C-collar, and it causes worsening of paralysis, or starting IVs without accepted technique, leading to an infection. All of that is a form of tort, and it can lead you to getting sued from it. Now, let's say the patient dies from that act, then you may be looking at criminal consequences. The law recognizes there's two classifications of torts: unintentional, which is usually negligent, and intentional tort that describes intent to cause harm. Now, intent is usually going to have more of a criminal effect, whereas a lot of times the omittance and negligence may or may not get to that point, but it's usually always some type of monetary deal. So torts are defined as civil wrongs and usually kept outside the criminal courts. Now, all four of these elements must be present for negligence to be ruled out. So you have to have all of them, not just one of them, but they all have to be substantiated. Now, duty, that's the obligation to provide patient care in a manner that is consistent with the standard of care established by training and local protocols. And that responsibility usually becomes from a statute or some type of function. A bystander, like we talked about earlier, a bystander is under no obligation to assist a stranger in distress and therefore has no legal duty to act. When you do have a legal duty to act is if you are on duty, you are being paid to function as a medical professional, you're dispatched to or witness an emergency while on duty. You've got a duty to act. The policy of your service or department states that you must assist in any emergency. If that policy says you must assist and you don't, then you've breached your duty to act. Once your ambulance response to a call or treatment is initiated, you have a legal duty to act. In most cases, if you are off duty and come upon a crash, you're not legally obligated to stop and assist patients. Of course, the laws vary from state to state. I do know in Mississippi and Louisiana, you're not required to stop when you're off duty. But you need to be familiar with those. And a breach of duty, that occurs when a person is accused of negligence, failed to act as another person with similar training would have done under the same care or similar circumstances. A breach of duty may not involve doing less than the person was trained to do, like an example for failing to splint an injured extremity, or doing more than a person was trained to do, like if you're an EMT and you suture up a laceration when doing so is not within your scope, that's a breach of duty. Damages, it has to prove that damages that occurred, and that is the objective of a civil lawsuit with some tort compensation. It's when a patient is physically or psychologically harmed in some noticeable way, even psychologically. Now, how hard is that to prove or disprove? That's not it. That's something that they can put on you. Although physical injury is usually part of the lawsuit for medical negligence, patients also may claim damages for emotional distress, loss of income, loss of enjoyment of life. Now, how do you, it makes me wonder how you measure that. But loss of spousal consortium, loss of household services, and loss of future earning capacity. Those are things that, the damages that happen to them that they might try to turn around and sue for. Proximate cause is when it's in a sense of medical malpractice. It considers whether the alleged harm to the patient would have occurred but for the negligent act. In other words, would this have happened without them doing the negligent act? And if, the man, they started an IV on him with a dirty needle and he got a bad infection from it. Well, would he got an infection without that needle? No, he wouldn't have. Well, then that's proximate cause. If the injury would still have occurred regardless of the alleged act of malpractice, then no valid claim exists. But if you have a legal duty to act and abuse it, causing harm to another individual, then you, your EMS agent, your medical director may be sued for negligence. All of you can be sued, even you as a person. There are medical insurances out there, malpractice insurances for EMS and stuff like that. And that's always a good idea to have that, because I've seen people get pulled into court personally. They want to sue John Brown, paramedic, along with the ambulance company and his medical director. So there's a possibility. I'm not trying to scare anybody, but it happens. Abandonment, basic term for that is termination of care by the AEMT without patient's consent. And it's pretty much like, well, hey, this patient still needs stuff to be done, and you terminate that care. Once care started, once care is initiated, you have assumed a duty that must not cease until someone of an equally competent person or of equal or higher level of training takes over. In your case, it could be another AEMT, a paramedic, a nurse, or physician. And not fulfilling that duty exposes the patient to harm and is the basis for a lawsuit. One of the best ways to avoid that is remember what your responsibilities are, and only turn it over to somebody that can do the same thing that you've been doing. Abandonment is legally and ethically a serious matter, and it can result in civil action against you. Instances where abandonment might take place, just like, for example, at the scene, leaving patients that you have assumed care for at the site of a single car crash to care for people injured at another site where two cars have crashed. Leaving one patient to care for another, even if that patient still needs to be treated, can be abandonment. Now, situations of mass casualty and things like that, where there's a triage in progress that you may have to do, and that does take on a different light. But there again, you're able to say why that happened. So, or in the emergency room. Now, I've heard a lot of debate on this and stuff, but in the ED, where you drop off your patient, AEMTs are responsible for providing hospital care personnel with a report of assessment findings, the emergency medical care provided, and changes in patient status that occur during transport. So, there's a saying that, once you're on their property, or if you're 250 feet, it's their patient. Well, stop and think about it. They need to know something about it. That's why when you get there, it's important to notify them immediately that you're there. A lot of places will go ahead and do triage or come up and assess the patient and put a band on them. So be sure you just can't drop and run patients, leave them there without doing a proper patient transport, because it will come back and bite you in the butt if you just drop a patient and leave, and that patient needed something else to be done and the staff wasn't advised of it. Then you've pretty much set yourself up for an abandonment negligence. So, if you fail to file a PCR and it results in a delay of treatment or misdiagnosis, a claim for abandonment could be filed against you. Now, used to, we had to leave a copy of the paper report every time we dropped somebody off. That has, that's not always able to be done now. Now I think they've made a law of it's like 24 hours where certain reports have to be filed within the facility. That does vary from state to state again. So know what your local protocol says. But what happens on your report does become a copy of their record, and it does have some valuable insight to the hospital providers. Assault and battery. Assault, you don't have to touch a person for assault. It's a criminal prosecution is an action taken by a government body against a person the prosecutors feel has violated criminal laws. Sometimes the same allegedly wrongful or harmful act that gave rise to a lawsuit may result in criminal prosecution. Like in a criminal case, the government must prove beyond all reasonable doubt to a jury. In a civil case, you pretty much only have to convince one person. Any of you remember the J Simpson trial years ago? Now, I had a question as how he was found not guilty in criminal court. However, in civil court, he was found guilty and responsible for people's deaths. And I'm like, how in the heck is that possible? But what it comes down to, in criminal court, you have to convince 12. In civil court, you usually have to convince one. So that's how that happened. So criminal cases have to go before a jury. If the government succeeds, then the defendant can be fined, imprisoned, or both. The criminal laws most likely to apply to pre-hospital care include assault, battery, kidnapping, and false imprisonment. Now, what makes something assault? Assault is you really don't even have to touch a person, but threatening a person, causing a person to have fear of immediate bodily harm without their consent, regardless of whether the threat of harm is actually carried out. That's assault. For example, threatening to start an IV line on a patient using a large needle. Hey, you scared them, but you might hurt them out of a threat. That could be considered assault. Or threatening to restrain a patient who doesn't want to be transported to the hospital can be considered assault. And of course, it includes providing care without consent. Battery, unlawful touching of a person. It's making physical contact with the patient before asking if you may touch him or her. That can be considered battery. Just about any act of medical treatment performed without consent can be considered assault or battery or both, because such acts constitute a threat to the patient's bodily security. So, consent is a big deal. Some people think it's crazy, but I've gotten a habit of I always try to find out their name first. What can I do for you? What's going on? And then I'll ask, do you want to go to the hospital? A lot of times I get an answer like, why the heck do you think I called you for? Well, I've just learned the hard way, not through myself always, but watching other people. Consent is something that needs to be made purposefully and acknowledged. Yes, because when they get that bill, they're going to say, "Oh no, I didn't want them to go to the hospital." It's like, yeah, you told me why, and you'll document that. But assault and battery can resort in civil or criminal in nature. To prosecute a criminal charge of assault and battery, the prosecution generally needs to prove the intent was to cause harm. And in a civil case, the plaintiff only needs to establish that the conduct took place with or without his consent. The kidnapping and false imprisonment. Now, kidnapping is defined as seizing, confining, abducting, or carrying away of a person by force. In theory, it can be a situation where a patient is transported against his or her will. Criminal charges of false imprisonment or kidnapping, it's rarely fought against EMS providers, but it has been, or we wouldn't be having the discussion, or it is a potential that can be done. So in reality, criminal charges of kidnapping are almost unheard of in EMS because the EMS provider is almost always acting in good faith effort to provide care to the patient. It's far more likely that EMS provider could be the target of a civil lawsuit or false imprisonment. Now, what false imprisonment means is it's unauthorized confinement of a person that lasts for an appreciable period of time. Now, I've had police officers say, "Hey, take this patient. I'm not arresting them right now, but I'll meet you at the emergency room." We do not have arresting powers. If that patient is competent or oriented and they want out of that truck, it doesn't mean if they just robbed a bank. If they want out of that ambulance, you got to let them out. If the police didn't want them to go, then they need to place cuffs on them and ride with them and keep them in custody. But trying to keep that patient in there, you do not have arresting powers. They're alert and oriented and no threat to themselves. Then you can't hold them. That can be considered false imprisonment. The Good Samaritan laws. I get a lot of questions on. I think I missed one. I'm sorry. Defamation, slander, and libel. These are some terms that basically define. Defamation is simply you're injuring or damaging someone's reputation, whether it be making a false statement, you can write it or say it, something that defames their character, saying, hey, this person was, hey, I picked this guy up at a bar the other night, man, he was drunk, he'd peed all over himself, and it gets around, and otherwise he may have been somebody that had a good reputation otherwise, other than what you just said. That's defamation of character. That's something that we're not supposed to talk about. Now, libel, that is writing something down that's not true. A false statement is written down, it injures a person's name, reputation, or standing in a community. That's punishable. That can be you can be sued for that. When you write a PCR, you don't want to use terms that can be considered judgmental. For example, I'm not going to write, man, this guy's a child molester, or this guy's a rapist, or you can't label people. You can't make a statement that that may be subjective. You want to be objective in it. Like if I know somebody hit somebody else, I don't say that. I don't say this vehicle struck this vehicle. I'll say patient's vehicle sustained damage to the front end. I'm not going to say they rear-ended or they did that, because that can actually, they could say, hey, so what made you say this? Did they tell you this? That can get you in trouble. So don't make conclusions in there that's not objective. Slander that's a verbal statement, simply saying it to somebody, to other, talking around. Somebody can actually overhear a conversation, and it defames their character, or it's not true, or it's not true about them at all, or it's false. Then that's what slander is considered. So we don't want to use terms that can be judgmental or offensive to the patient, like talking amongst each other or making a judgment when you're handing it off to like a nurse at the hospital. Like, hey, this guy's an idiot, or he's just a drunk, or he's a drug addict. You don't want to make that kind of statement, because it can come back to haunt you. Now, the Good Samaritan laws, it basically, like, hey, Good Samaritan laws are based on the common law principle that when you reasonably help another person, you should not be liable for errors and omissions that are made while giving good faith emergency care. Now, most states do have these laws. I'm not familiar with exactly what Louisiana says, but I know Mississippi says that even an EMT, doctor, nurse, that stops to help somebody in good faith, that does not willfully do anything wrong or perform outside their scope, is protected under Mississippi's Good Samaritan law. I'm not sure about Louisiana or Alabama, but some states, Good Samaritan laws only protect people that are non-medical. But I know Mississippi does protect people that are medical if they act in good faith and do not willfully or do gross negligence to perform harm. But some states only cover people that are not medical.
Louisiana is the same. The distinction is drawn whether or not you're on duty. So, if you're a paramedic in Louisiana and you stop off the clock to help somebody, you can operate to your full scope and be protected by Good Samaritan.
Okay.
But if you're on the clock, obviously Good Samaritan doesn't factor, because you have your duty to act, which negates that law in that context.
Good deal. Exactly. Okay. Well, thanks for that. Anybody know anything about Alabama? Tennessee? All right. Maybe something that y'all need to look up, maybe pass on to the rest of us. In in some jurisdictions, they only provide immunity from a lawsuit. In others, they provide an affirmative defense. In some states, they don't defend you from a lawsuit, but they may be a defense that you could use. So, and in most cases, they do not prohibit the filing of a lawsuit. People can still try to sue you for it, but when it goes to court, they may say, "Hey, no, this guy acted in good faith. He meant no harm. Here's what happened. You know, he was dragging this guy from a burning car, and he dropped him and hurt his leg. Oh, well, okay, he sued you for hurting his leg. But when he goes to court, well, that's a good defense, but they didn't mention that the guy's 450 pounds and he was by himself and he would have got caught on fire if they'd have left him. So, I mean, it might be something based on that thing. So, but these laws do not pertain to acts that could be considered wanton, gross, or willful negligence, or if care is provided for payment. Some of them don't pertain to that at all. Another group of laws that grant immunity from liability to official emergency medical providers such as EMTs is they got them in certain states. We'll have to look it up, see what got this. But these laws vary from state to state. But they don't provide immunity when injury or damage is caused by gross negligence or willful misconduct. In most cases, immunity statutes apply to EMS systems that are considered governmental agencies. Now, a lot of government agencies say that, hey, you can't sue them. They are protected. They're immune from lawsuits if they're acting with the municipal service. I've seen some places that says, hey, you can't sue the police department, or the fire department is not subject to lawsuit. And in some cases where they're under municipalities, they are. I know Washington, D.C., I happen to know the ex-medical director from up there, and she left it because they were granted what they call sovereign immunity, and it's a form of legislation that identifies only limited types of lawsuits can be filed against governmental agencies. And these people knew it, and they were negligent, they were lazy, a lot of paramedic initiated refusals, and she was without any power to try to fix that, and she ended up leaving. So there are some places that are like that. In other words, they can hurt you and you can't do nothing about it. So EMS personnel working for government agencies have some governmental immunity for their actions. Government immunity generally applies only to EMS systems that are operated by municipalities or other government entities. If your service is covered by immunity, then it may mean that you cannot be sued at all, or it may limit the amount of monetary judgment that the plaintiff may recover. Of course, these state laws do vary, but the statute of limitations may also aid in protecting you from litigation. It limits the number of years after an incident during which a lawsuit can be filed, set by law. It differs for cases involving adults and children, and varies state to state. In other words, child abuse or rape or something like that, in a lot of places they don't have any statute of limitations. Now, this may be seen as, this can be like fire. It can heat you up, or it can burn your house down. Now, what's sad about it is that there may be some places to where the negligence, like the example I gave you, continues and nothing can be done about it. And on the other hand, 10 years from now, like, hey, you made a mistake, it's an honest mistake, nothing was done about it, everything's cool, you didn't do it willfully. You don't want somebody coming back after all that time and then trying to sue you for it. So it is kind of a double-edged sword. Consult your medical director or state EMS agency for more information about the laws in your area. Most states have adopted specific laws granting special privileges to EMS personnel, authorizing them to perform certain medical procedures. And some states also grant partial immunity to EMS providers, physicians, and nurses who give emergency instructions to EMS personnel via radio or telephone or other forms of communication. Emergency medical dispatchers, like we talked about the other night, a lot of them do give medical advice over the phone on how to do CPR and things such of that matter. So consent, permission for treatment, it's required for every conscious adult before treatment can be started. Under most circumstances, consent is required for every mentally competent adult before emergency medical care can be started. Any touching of a patient's body without that consent can be assault and battery. So you need to ask them, hey, can I help you? It sounds crazy, but we need to cover that base, especially in this litigious environment that we're in now. So if the patient is alert, rational, capable of making informed decisions, then he or she has the legal right to refuse emergency care as well, even though ill or injured. So, the patient may consent to some aspects of medical care and deny others. It's like, well, I'll go to the hospital and I'll take oxygen, but you can't start an IV on me. If that's what they said, then it's like, hey man, your pressure is very low. He says, well, I don't care. Okay, well, they're aware of that. So if a patient refuses emergency medical care, then you can't care for them. Even if they've got an arrow sticking through their head and they say, leave me alone, you can't do nothing for them. So, and then consent, it talked about consent can be either actual or implied. Now, what that means is that if you tell somebody, hey, I'd like to start an IV on you, and they hold out their arm for you, or they hold out their arm for you to take a blood pressure, or to allow you to put a splint on, or maybe if they climb up into the back of the truck, that's implied, that's actual express consent that you are able to, that they want treatment. So, and they got to have decision-making capacity. They got to be able to understand what you're doing, what you're providing, and they got to be able to process that. They got to be able to make an informed choice. For example, sir, I need to give you some nitroglycerin for your chest pain. What this does is open up the arteries to provide blood flow and oxygen to your heart. However, it may cause you to have a headache, and there's a chance it may have an effect on your blood pressure. And but I'd highly recommend this. So you need to don't do anything that's going to surprise them. They need to be made aware of that. So one of the best ways to know this is to talk to them, make sure they understand what's going on to him or her. But something if they're making irrational decisions and you got a pulse ox of 50 or a blood glucose measurement of 20, those are outside normal ranges, and those readings can provide pretty much measurable information regarding their ability to understand and communicate. You will not win something for not treating someone with a blood sugar of 20 because it needs to be 70 to 115 or 120. So that's some things you need to be able to say why. Well, why did you have the police to hold this man down while you started an IV? Well, he had a blood sugar of 20 and he was combative and he was talking out of his head. I don't think he was capable of making an informed decision. And when he wakes up, he's probably the nicest person in the world. Going to thank you for it. Patient autonomy, the rights of patients to make decisions concerning their care and to decide how they want to end their life and medical care provided to them. So the assistance of medical technology has made the distinction between life and death more precise. My PowerPoint went dead again. Let's see, number 21. The consent, it requires ability to understand what information they're trying to process, and the best way to do this is to talk to them. Now, we go back to making a decision between life and death. A number of high-profile cases have been brought to the issue of patient autonomy in a lot of medical ethic debates and stuff over the last 20 years. And some of you may or may not remember the case of Terry Schiavo in Florida. It's been about almost 20 years ago. This woman was in a vegetative state in a nursing home, and she had no hopeful prognosis of her ever recovering, but she had her eyes open, but she had no communication. She was kept alive by a feeding tube, and her husband wanted to pull that feeding tube from her and allow her to die, which it sounds cruel in one way, but then he said he had her best interest at heart. He was the closest relative. So people from all over the world stepped in on this and said, hey, no, they should keep her alive. They should keep her alive. But he was thinking, man, I love her. This is no kind of life that she'd want. So that led to the courts getting involved and him being able to have the tube withdrawn and her be able to die. So what does that come to nowadays is that, when that happened, my wife said, hey, I don't know what I would do in that situation. So I said, well, I'm going to take that decision from you so you don't have to make it. And I went ahead and had a legal plan made that to where if I get to that point in my life, no, I don't want to be kept alive artificially. So that decision's already made, and she don't have to worry about it. And it is a good idea for people to go ahead and do that because it can come out to some very painful and ethical debating later. So that's why we say that make sure that they understand what's happening to him or her, that and that they're able to acknowledge what they want or not. Now that has to be if they are able to understand it. So patient may be able to acknowledge whether or not they want patient care or transport. This is called actual consent. It's called express consent, and it's a type of consent that when the patient acknowledges that he or she wants you to provide emergency care, then that's when you may carry it out. You must obtain informed consent for every adult patient in order to be able to transport. To obtain this consent, describe what their illness is, what's going on with it, what you'd like to do, if there's any alternative information available, and consequences for refusing it. I had a guy the other night that didn't want me to start an IV on him, but he wanted me to give him nitro. And I said, well, first off, my protocol don't allow it. And that was kind of one of my judgment or one of my excuses. However, I do know that nitro can lower blood pressure dramatically, and without an IV, you can't treat it. So that's what I left it at with that. To provide informed consent, a patient must be of legal age and able to make that decision. So people can refuse part or all of their care. Like I said, they may want to get oxygen, but they may not want an IV, and that part needs to be documented. But you can't force it on them if they don't want it. Implied consent is when, like, you go back and think about what a person, a reasonable person in the same circumstance may or may not want. So implied consent is when a person might be unresponsive, unable to make an informed decision, but you would assume that a normal person would want their life saved. So this is usually limited to true emergencies only. And something that's like, well, they're not really in a danger of dying if nothing does get done. But for example, if they're unconscious and they're unresponsive, they're delusional, they're an altered mental status, might be under drugs or alcohol influence, otherwise physically unable to give express consent. So, don't rely on implied consent unless a threat to life or limb exists. Because I have had people said, hey, I didn't want to be transferred to the hospital, blah, 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 stuff like that. So be sure you're able to say why it's done. But usually before I take somebody against their will, it's usually because there is a threat to life or limb to it. Not just because they're groggy or sleepy, but you want to be able to justify that because sometimes they just don't want to go. And if they wake them up in the back of the ambulance, then I've had fights start out back there too. So implied consent, true emergencies only. And this allows some people to interact in critical situations without the danger of recrimination. The exact situations or conditions that represent these life threats might not be unclear, and it can come down to a legal question. So what you'll do, these efforts and reasoning for going ahead, is you want to be able to justify in your PCR or your documentation. Now, medical legal is a term that you'll hear later on, and that relates to medical jurisprudence or forensic medicine. So it's a good idea to try to get consent from a spouse or relative before leaving, based on implied consent. That is, if they're not alone. However, never delay treatment if the patient has imminent life-threatening injuries. I have had patients that were unresponsive in somebody's yard, snoring type respirations, and the family's like, we just want you to get them inside. Now, is that a good idea just to take them inside and leave them? You know, what if they don't wake up the next day or they go in there and die? Then guess what's going to happen to you? So I've had to get the police involved, medical control involved for situations like that. Like I had an old lady passed out in the front yard, snoring respirations, and the family's like, man, she's faking. We just want her put inside. We don't want her taken to the hospital. Well, I got med control involved and the police. It turned out, yeah, she was having a major brain bleed. So just imagine what would have happened to me had I put her in bed and she not woke up the next morning. You know, she ended up dying from that injury anyway a few days later, but at least I did my part. Nothing could come back on me because I was acting in good faith. So, refusal of emergency care may also be implied, such as, for example, they're awake, alert, and they pull their arm away from you. They said, hey, I'm going to splint your arm, or I'm going to start an IV, and they just pull their arm away from you. But, you know, no, you're not. So that's, you would document that. Hey, I attempted to pull the IV on a patient, but they pulled back 3 times. And looked at me. I ain't talking about somebody that's unresponsive, combative, might be pulling away, but somebody that willfully pulls their arm away and doesn't say anything, you know, that could be considered, you know, that's an implied refusal. So if you're treating a patient, they're unresponsive and they get D50 or Narcan and they wake up and are fully awake and alert and said, hey, leave me alone, let me go, then you've got to let them go. Because if they're being treated under implied consent and they regain consciousness and appear capable of making that decision, then the implied consent doctrine no longer applies. So like I said, it's seen a lot with patients with hypoglycemia that have to be woken up. Minors, the parent or the guardian has to give consent to treat minors. And what makes a minor is they say that they're not smart enough, they don't have the maturity or been able to give valid consent unless the parent or guardian gives it for them. So in every state, if a parent cannot be reached to provide consent, then health care providers are allowed to give emergency medical care to a child. Now that doesn't mean just non-emergent care or something like that, but if it's emergent medical care that they need, and it says here in every state, then it's allowed, it's considered implied consent. In some states, a minor can give valid consent to receive emergency medical care depending on the minor's age and maturity level. And I know in the state of Mississippi, that age is 16. Even though it's not advertised a lot, but a patient in the state of Mississippi, if they're 16 or pregnant, they can decide whether or not they want treatment or accept treatment. Some places there's what they call emancipated minor. A person who, despite being under the legal age in a given state, can be legally treated as an adult based on certain circumstances. You know, many states consider minors to be emancipated if they're married or if they're members of the armed services or if they are parents. A minor may also be considered emancipated if he or she is living with away from a parent that's no longer on their support, and a minor whose a parent may give consent for his or her own child. So, but I've never seen that there's a card that verifies that. I've never seen that. Hey, I'm an emancipated minor. I've never seen it. There might be one somewhere, but I've never seen it in all my years. So, so if it's at all possible, if a parent's around, you know, try to get consent. Now, what we call in loco parentis is someone that a child has been entrusted to their care. Or many times it can be like when they're at school. There should be something on file that the school official is able to give consent whether or not treatment's to be done, or can give consent for that. School administrators, a lot of time, if they go to daycare or camps, a lot of them will require that decision be given to them to make those decisions on behalf of that minor. So, you know, always try to make contact with a parent or legal guardian. However, don't withhold life-saving medical care for a minor because authorized patient is not able to be given consent. Now, also, in the same fact that they can't, this is kind of an oxymoron in a way, but in the same manner that they can't give consent, a lot of times they're not able to refuse either. This is a how many of you don't? I'm one of them. I don't like to answer calls from on my phone that I don't know who the number's from, and I've had that happen before to where I've tried to call a parent for something that wasn't so serious, and they never answered. Well, I don't answer strange numbers. And I'm like, well, I got your child on the side of the road. I really need to talk to you, So that's something to think about and pass on to people in some of your classes if you do later on prevention or health and safety classes for the public, because a lot of them are going to answer, hey, what if, and that might be something you want to bring up to them. Is like, well, no, do you have to ever answer a call that you don't recognize? No, but if my kid is out riding around somewhere and I can't get them to answer me, then it might be a good idea to answer a phone call. So that's something you might need to pass on to them. So state laws generally do not permit a parent or guardian to deny treatment to a minor. Now, a lot of time it takes a court order. That can be a very tricky situation, and I have seen it happen. The failure of a parent or guardian to allow such treatment may constitute neglect. And I've seen physicians and ER social workers tell parents that. They're like, well, I don't want my child to have this done. It's like, well, if you don't, then it is considered neglect. But without this antibiotic shot, your child may suffer big time infection and stuff. So I've seen things like that happen. So if confronted with such a circumstance, notify law enforcement or med control. There again, you really don't have the authority to take a child out of somebody's hands and run off with it. But that's why those other authorities get involved. And let's say, and I've had the police say, hey, we can't get involved. We have no jurisdiction here. And the parents like, hey, look, this is my kid. I'm out of here. There's nothing really else you can do about it other than document the heck out of it. Involuntary consent. Now, this is ridiculous because consent means permission. So how can you have involuntary permission? You really can't. So that's why they call that an oxymoron. So involuntary consent, and I guess where they get this from is some personnel incorrectly use the term to consent or refer to situations like if a law enforcement officer has a patient in custody and he's like, well, no, you're going to treat this guy. Well, that still doesn't take a person's civil or fundamental rights away, whether or not they want treatment or not. It doesn't. So they still may have a say so of whether or not they get treatment. So just be aware of that. People under this term, they apply sometimes to the mentally ill, developmental delayed persons, incapacitated people, or minor for other reasons. But involuntary consent, consent cannot be considered involuntary because that simply means permission. But people under arrest or in prison do not necessarily lose their right to be involved in their decisions. Even people in nursing homes, if they're alert and oriented and they have a right mind, they have a say so to say, no, I'm not going. Or I know my paperwork says I got to go to this hospital, but I refuse to go to this hospital. I want to go to that one. I had that happen just a couple of weeks ago. If a law enforcement officer directs EMS personnel to treat a person under direct, you should continue to follow informed consent guidelines. If the guy says, no, you're not touching me, the officer's like, no, you're going to take care of that. Don't touch the guy, because chances are this may go to court. And if the officer's right, what can they really get you on? But if he's wrong, then you're going down with him. So if a prisoner refuses treatment, the best thing to do is call med control or your supervisor at that point, but get med control involved. And when a true emergency exists, you can assume that implied consent does exist. Forcible restraints. Now, this is a tricky one. It's simply the act of subduing someone, act of physically subduing a patient to prevent harm. And it may be necessary if you're confronted with patients who are in need of medical treatment and transportation but are physically violent, present a significant risk to others. Now, there again, this patient was fixing to run out in front of cars. He was talking out of his head. He was violent. He was a threat to me and my partner. In that case, I can say exactly why I'm applying physical restraints. Now, if he's to the point where he's going to hurt you and your partner, then police may need to restrain that patient. If they don't want to get involved, then your hands are kind of tied, because there again, you don't want to put yourself in a situation where you can get the heck beat out of you. Now, this type of restraint, forcible restraint, it's illegally permissible if you believe the patient is a threat to himself or others. Document that you believe that and why you believe that. What actions or exhibition do you see that justifies that? That states that he was a danger to himself or others. Some places may require, if there's not an immediate threat to life, medical control may have to be called for authorization. Some states, only law enforcement officers may forcibly restrain your patient. There again, look at what your policy says in your local area about who's to do that. That should be in your procedures of your service that you work for or a part of. That needs to be a procedure written in there on who can do that. So know what your local laws say, and restraint without authority or justifiable reason, it could expose you to civil and criminal penalties. Restraint may be only used in circumstances that's a risk to the patient, yourself, or others. And there again, you should have that already in writing somewhere, some type of a procedure. If not, that's something you need to be made aware of, pretty quick, because it could be your next call. But if you do apply restraints, they don't need to be removed en route. Don't make a deal with a patient because they're probably not going to follow through with it, even if they act right. But you got to reassess, make sure they got good circulation, document every time. Hey, reassessed at 9:05, good circulation, good distal pulses, capillary refill were positive and symmetrical. Right to refuse treatment. Conscious alert people who can talk to you, make sense, know where they are. They can refuse or withdraw treatment at any time, even if it's on the side of the road, even if it is a life-threatening injury. They said, "Hey, I'm done. Let me out. I stop. I deny consent." You've got to really, if that's what they want, I'd call med control and get them involved. And I've been told before, hey, if that guy wants to lay there and die, that's his right. That's what I've been told by medical physicians before. So, but these patients, it can create an ethical dilemma for you. And but do you do it against their will? Do you leave them alone? There again, that might be one of them times. Is what you do, what's in the best interest of the patient. Be able to say why you did it, and hopefully the chips will fall in your circle. So, but calls involving refusal of treatment are commonly litigated in EMS and require you to proceed very cautiously. So if you leave a patient alone, then you risk being accused of negligent and abandonment. They get worse. And you might face charges of false imprisonment if you transport against their will or against their wishes. So there again, they may ask you, why did you do this? And just be able to say why. Hey, I did it in the best interest of patients because. When they do have the right to refuse if they meet the criteria. So, but make sure they understand what's going on and you document that. Hey, I told the patient, he's having chest pain. I did tell him that he could possibly have a heart attack, and without treatment and transport to an emergency room can result in a lethal or a fatal outcome. The patient states that he understands this. Transport was offered and encouraged. However, he still declined to continue with care and get them to sign it or get a witness to sign it. Now, sometimes they may refuse to sign it. I have that happen a lot. So, but to refuse, they got to be alert and oriented to place, time, and event. Ensure they don't have an altered mental status, but document the heck out of it. If you have any doubts, consult med control for direction. But the best way to do it, I don't try to scare people and I don't beg people, but I do give them the facts. And it's like, hey, there's a good chance you may not wake up tomorrow without this. This is just the truth. And I've may have come dramatic about that sometimes. Like, hey, you got a wife, you got kids to raise, and with they'd hate to not have you around anymore without getting seen and this checked out, because this is what could happen. And I've had the kids even talk to them and get them to do it, but but you need to document your efforts. Got a refusal on a woman one time in Picayune, adamantly refused. I knew she needed to go. The other crew went out there that morning at 6 o'clock, pronounced her dead. So she must have died right after I left because she'd already had rigor mortis in the face and the neck. So, but keep in mind, people who refuse medical treatment do so out of fear, sometimes emotional stress. You need to recognize what the problem may be. A lot of people say, like, hey, I don't want this bill. This is going to cost a lot of money. Or they might deny that something's going wrong. But address those. Might need to work on your people skills, and but try to urge them to go. The biggest things people are sued for in EMS, one of them is because of the refusals, and the other one is a lot of times misplaced airways and stuff of that sort. Even if they don't go with you, you want to urge them to try to follow up and document that. You know, say, hey, I need you should at least, I request that you go directly to the ER, follow up with your physician. Also, call 911 if anything changes. I will document on my report that I advise the patient to call EMS back if the situation changes. Now, what does that say? That covers a lot. They change their mind, or they got worse. They just someone talked them into it. But I'll kind of word every one of my refusals with that: call EMS if the situation changes. And that way, if I did go to court on it, I said, well, I told them to call if it changed, and that meant that could mean this, or that. So I just got in the habit of putting that all on there. So some may want you to take them to the hospital and not treat them, and then someone may want you to treat them and then refuse to go. Now, a rule on that is I don't give narcotics on scene. I give it en route to the hospital unless they're having a seizure or something, because, hey, some people want to fix, and they've learned how the system might work. But then you got to think, well, I just gave this patient a milligram of Dilaudid. Are they competent to make a decision like that? See, so that can get real sketchy. So, and that has to go with common sense. Why did you not give this patient Dilaudid? Well, he didn't want to go to the hospital. I figure if he really was hurting that bad, he probably would have went with me. So, a lot of that just comes with the experience. But if you do treat someone, like give them D50 to wake them up, or I wouldn't leave them there without someone to be there to watch them. One way to avoid that is, hey, don't give them D50 or nothing until you get them in an ambulance on the way to the hospital. Sometimes that happens if someone's going to be by themselves. If you give them D50 and wake them up, that ain't going to last a long time. That's only going to probably last an hour, if that, and then they'll go back into their hypoglycemic state again. So, but although adults do have the right to refuse treatment for themselves, state laws generally do not permit a parent or legal guardian to deny treatment to a minor. Now, you might have a blow up on scene, but that's something I would call med control in and get them involved in. But a lot of time, if you've got good people skills, calm persuasion, you might want to get some examples, but that might be one way to persuade them to do it. Call med control, put it on their back. You don't want to take that responsibility by yourself, and ask them if they would get involved in this. Hey, doc, I want to run this by you, but here's what I think might be going on. So if you're unable to get consent, document any of your findings in your care. Note how much time you spent with the patient, and all the information that you provided to them, what you try to get them to go with. There again, when it comes down to you, it's like, well, yeah, you're suing because you woke up paralyzed on your left side, but man, this medic, this advanced EMT, he went through all the steps here to try to get you to go. However, you still exercised your right to make an informed refusal. So that's why you got to justify that. If try to get them to sign the release form, sometimes they won't sign it. If not, get a witness there. Now, a lot of fire agencies and stuff some of them don't want to get involved with signing the witness sheet, and that's fine. They're following their policy and things like that. However, just there's a place on, I know that most of the medical reports that you can document, hey, what other kind of assistances you have. You might want to put fire station, or like this is just an example, but say you might want to say, hey, Harrison County Fire Unit 1 assisted us. And if it comes to a big thing later on, at least they know all who was there. But regardless if it was a refusal or not, it needs to be made known who was there. Like assistance was provided by, Pearl River County Fire or Alabama Highway Patrol. Whoever was there with you just needs to be documented. Not throwing anybody under the bus. It's just Sometimes there are no friends in the courtroom. Advanced directives, that was the word I was trying to think of earlier. But these specify treatment if the patient becomes unable to make decisions. Living wills, DNRs, even organ donation cards. Now, in all my years, I've never looked to see if the patient was an organ donor. One reason is why a lot of times the cops had the driver's license, but I've never looked at that. And organs can only really be donated under very strict guidelines. In other words, if they've lost a pulse in the field and they never get it back, then they're probably not donating anything. The ones I've seen that usually donated, it was ones that was alive, they was probably brain dead or had a terminal event, but they were still being perfused on a ventilator, ECMO machines, or something like that. So it's a very delicate parameters on whether or not organs can be transplanted into somebody else. But healthcare directives, living wills, that's something that I encourage everybody to get on file. Some places can do them online through your state, but that is something to always get online, because if you've ever seen this happen in the ER about people wondering what that person would have wanted, or what, if you talk about it ahead of in the time that an emergency happens, nobody's thinking straight. It's an emotional turmoil, and people don't make the best decisions. So that's why these things, it's a good idea to get them thought out ahead of time. But you need to ask when you're on scene, do they have any type of an advanced directive? Some of them will have a DNR, do not resuscitate. And for example, now it does vary state to state, but a DNR order, it gives you permission not to attempt resuscitation. Now, to be valid, DNR orders must meet the following requirements. Clearly state the patient's medical condition, signature of the patient or legal guardian, signature of one or more physicians that are their providers. And in some states, DNRs contain expiration dates. And in those states, the DNR order must be dated in the preceding 12 months to be valid. Now, I very rarely see anybody comply with all of these criteria. A lot of time, even the nursing homes will just have one form that says DNR, do not resuscitate, or medical code only, or no CPR, only drugs. Now, drugs aren't going to work if you don't do CPR, but I've seen that broke down to that list. So if there's any question or not, I would start BLS, start your basic CPR, airway, breathing, circulation, and then call med control if any of those things exist. Once you start advanced level stuff, then you might get into a different criteria, but that's what I would do with that. So, but a DNR does not mean do not treat. It simply means do not restore life-sustaining mechanisms. If they stop breathing, don't put it back. If the heart stops, don't put it back. It simply means that. But if they have a heartbeat and they're breathing, it doesn't mean you should provide comfort or supportive measures. Make it easier for them. Oxygen, pain relief, comfort. Do that. It's just that, you can keep things going, but if they stop, don't restart them. So, every EMS agency, within consultation with their medical director, legal counsel, they ought to develop a protocol to follow in these circumstances. And it's usually probably in the procedural portion of it. Now, in the absence of an advanced directive or DNR, some patients may have a power of attorney or a healthcare proxy that makes these decisions for them, but it only applies if the patient's not capable of making any type of decision. So if a patient remains conscious and competent, and I've seen it happen, like I'm not going to the hospital, there's nothing wrong with me, but there's somebody that says, I got power of attorney, and I say they go. No, that only applies if the patient's not able to make any more decisions. So don't get caught up in that. But there again, you may have to call med control about that. So the person that's named in the healthcare proxy or power of attorney only can make decisions, like I said, when the patient's no longer capable. I've seen people that have power of attorney. Well, I want them taken to the hospital. I just want them out of here because they're tired of dealing with them. Well, they don't have that authority unless the patient's unconscious and can't speak for themselves. When I was a manager on the coast, I had a medic call me one time. He said, hey, the family says they have power of attorney and they demand this patient goes to the hospital. I said, well, they might demand it, but nowhere, even the deputy was telling me, hey, they got an order here that says they have power of attorney. I says, but nowhere in that, I said, they can make her go to the hospital, but nowhere in that order does it say we have to take her in our ambulance. So you might want to put that off on somebody else to make that decision for you. But power of attorney only works if they can't talk to themselves, and they can verbally revoke it. They might be a DNR, but all of a sudden this patient says, hey, I want to be resuscitated. It doesn't work that way with the family. However, that would be a medical control question. But if the patient says, I don't want to be a DNR anymore, why don't you try to save me? Well, that DNR has been revoked. You just got to document it. So some other times that resuscitative efforts might apply would be like, for example, considered futile. And futile means just not useful. It's not going to work. Situations where death is imminent, such as resuscitative efforts for this patient who's terminally ill. It's like and it happens a lot, man. You get to a call and they'll like, hey, man, they've got stage 4 terminal cancer. It's all over their body. They stopped breathing about 10 minutes ago and they don't want nothing done. Now, that would be one you'd want to run by med control. Say, hey, the family's in agreement with this. And when you call med control, don't go off with a bunch of stuff. Get to the point first. Hey, doc, I'm calling for consideration of a DNR or to withhold resuscitative measures, and here's why. I've got a 90-year-old man with stage 4 brain cancer. He stopped breathing about 30 minutes ago. There's no pulse, and he is in arrest, and the family has requested that we did not provide any resuscitative attempts. And 9 times out of 10, they're going to say, okay, if the family's good with that, then we're okay with it. So that is something that that we might have to look for, or you might have to run across. Bear with me again. My dang PowerPoint again.
Hey, so while you're trying to fix your tech issue, I wanted to also add in, when it comes to like powers of attorney. Hold on a second. When it comes to powers of attorney as well, they don't have to just be unconscious for that document to hold up. If they are having a altered level of consciousness or like they're not oriented, say if it's an Alzheimer's patient, they can't make their own legal.
You're still there?
Decisions while they're not in their right mind. So they're still awake. They're still talking.
Yeah.
Their words, they don't have the authority to say for themselves if they want to go or not.
Exactly. So he's exactly right. It means that they're not able to make those decisions, and this person has taken over for it in that situation. Now, so that's some things that might, and I've had that happen. Hey, Dad's 90 years old, and we'd really like nothing to be done. And I've run it by med control, and they've said, hey, is the family okay with that? Is everybody in the house okay with it? Because if one person objects, I've been told, go ahead and bring that patient to the hospital. So, and that's pretty much, it's nothing on you. That's just to cover all the bases. There is something else called Physician's Order for Life-Standing Treatment, or POLST. And that's something simply, it's an end-of-life document that emerged in the early 90s. It's also, and it's depending on like a location, like similar to DNR, but more expansive, and it encourages physicians to speak with patients with a terminal illness to create specific medical orders to be followed at the end of life. And a lot of times this is done ahead of time, but it's intended to be followed by healthcare providers, not just EMS. But while DNR generally applies to patients who had cardiac arrest, this other order may apply to patients with impending pulmonary failure who are not in cardiac arrest. It's like, do you want intubated? I do not, or do you want defibrillated if that was to happen? No, but and it contains provisions that address the initiation of CPR, intubation, feeding tubes, antibiotics or comfort care, and things like that, to be made ahead of time, to where when patients do lose their decision-making capacity, it is what needs to be used for that. So that's another type for that. we're winding down, guys. I know it's not a lot of exciting stuff for everybody. I just like it. So let me see where we are. This is something we kind of hit on a little bit earlier, so we're just real quick about it. Ethics, right and wrong, moral duties, ideal professional behavior, morality is a code of conduct affecting character, conduct, and consciousness. If y'all been around EMS any time along, you know that certain medics have reputations, and you know who you want to pick you up and who don't. So just be aware of that. The way you act and hold yourself is going to have a lot of weight on how you're perceived by other people. And you know yourself that there's probably people that you work with that you wouldn't mind picking up your family, and there's some that you would not allow around anyhow. So just be aware of that. So being honest with your patients, you don't want to lie to them, especially kids, because once you break that trust with them, they're not going to trust you anymore with it. Keep accurate records. Your documentation is paramount. I just can't hit on it enough about the way that if it wasn't written down, it wasn't done. And this is going to cover your butt so much later on. I'll give you an example here in just a little bit. Being good at your job, knowing what's required of you, checking off your truck, making sure you have what you need. That's all ethical. That might not be a legal thing, but it can get you in a lot of trouble if you're not doing it. But it just makes you being a better medic. Don't do it because of the rules. Do it just because it's just what's right. But some things you might run into is like, for example, triage. That's doing the most good for the greatest number of patients. And some patients you might have to leave that may have been viable under other circumstances. But if you got 10 people and there's only one of you and one's in cardiac arrest and the other one has an arterial hemorrhage, if you don't treat the arterial hemorrhage, then you're going to have 2 people in cardiac arrest. So that's a decision that you got to a lot of times fall back in your training with that if your judgment gets clouded. But being effective, safe, competent, coupled with accurate, complete documentation, it's one of the best ways to stay out of trouble. So treat these patients with the same consideration that you would want to give to one of your close family members. That's one way that's kept me out of trouble with through the years. So remember confidentiality. Your conversations or communication with these patients is private. It should only involve people that's directly related with the patient care as well. So, and if you do this, you can get in trouble. People put on Facebook, social media about calls that they've worked. They've taken pictures of wrecks and stuff that's turned around and got them in trouble. If someone was able to identify an event that they were associated with, then you can be in violation of the Privacy Act. And a lot of times it's going to be released with their permission, a legal subpoena. Third-party billing, they can receive that same way that you get a face sheet. The hospital is able to share that with you. There's some cases that you may have to report to the police, like abuse, rape, incest. That is really required by most EMS people, even though whether or not your supervisor or agency does it or not, that it is falls upon you to really report that. Some we're talking about the legal subpoena not being shared. I had a police officer once that refused to go into a house with us because he was scared that he might get sick from it. And it was a patient that was threatening suicide, and he wouldn't clear the scene. So I just took it upon myself, kind of broke some rules. I went in, and the patient was actually fine. But when I come out, he chose not for law enforcement to get involved. And when I come out, he wanted all kind of information. And I said, dude, I can't give it to you. You're going to have to get a subpoena because since you've excluded yourself from this call, any information I give you is actually a violation of the Privacy Act. So that kind of backfired in his face. The improper release of confidentiality can result in a liability on you. You could actually be in trouble for libel or slander. And then you want to be objective. Keep your personal opinions out of it. I know it's hard to do sometimes, but you got to remain away from that. Now, HIPAA is what we talked about before. There should be a privacy sheet that you give to every patient that you come in contact with. That's required by law that your agency gives that to them. I know one medic that took it to heart so much that he's actually put these inside body bags before. But this talks about what information is protected, what you can give away, and why it can be used. So that being said, if you've been to the physician's office or anything lately, they should go over this information with you. But remember, information is protective. Pretty much if they weren't on the call with you, there's really not a whole lot of use to talking to somebody about it. The records for complete and accurate records. Now, the reason that this protects you against legal complications, of course. And if you didn't write it down, it wasn't done. And I'm going to tell you about a couple of cases that happened to where the way a report is written can a lot of times have a great impact on the decision, the way the outcome is. So if incomplete or untitled reports or evidence are incomplete, and they actually will prove you providing inadequate care. I knew a guy one time that it went to court, and this guy had misspelled words, a lot of grammatical errors, like commas and stuff like that was out of context. It wasn't in the right place. And the guy did make a medical mistake that caused injury to this patient. But believe it or not, they never got to the medical part of it at all. The lawyer finally said, hey, man, if this dude cannot write a complete sentence, provide proper punctuation or spell accurately, how can he be expected to provide advanced medical life support? And right then, they had to settle because it never even got to that point, because the jury said, hey, this guy's an idiot and he shouldn't be performing it, without even getting to that part. Now, the guy skillfully wasn't a bad paramedic at all. However, just based on that, they found problems with it. So just be mindful of that when you write these reports. Your report is everything. So as far as reporting, I know in the state of Mississippi, if you go on a call and there's an abused child on it, even though your supervisor or hospital says they may do it, it can come back on you. You are directly responsible for reporting that incident to authorities. The Department of Children Health Services for elderly abuse or children, you're directly responsible for that. So be sure to learn that local number in your area. I have called myself because I have had supervisors tell me, no, we're not getting involved in this. And ethically, I thought, no, ethically and legally, I'm doing the right thing. They're not. So scene of a crime, you're going to run across this a lot, where this is where you can get in some conflict. However, of course, your safety is paramount. Don't go in there if the scene is violent, or if it becomes violent, you need to get out and you need to leave. But preserve the crime scene as much as possible. If you need to get in and get out, try to touch as less as possible. Try not to touch anything. If you do, please let it be known to the officers that are there that are investigating. Hey, I did touch this picture right here. I had to move it. Or, hey, we had to move this chair right here from this point to that point in order to be able to get to the patient. Be sure that they're know that. Now, this is a Mississippi law, and it says that if there's any chance of the patient's survival, neither the coroner or police on scene can stop you from providing it resuscitation. And that is a law. It's a statute. It's in the books. If anybody ever needs to see it, I can show you where it is. But anytime, like I said, in the state of Mississippi, that if a patient has a chance of resuscitation, neither the police or the coroner can prevent you from doing that job. If they do, well, they might can prevent it for you, but they're going to have some serious, there can be some serious consequences from that later. So if it's obvious, of course, don't disturb. Get up, walk out the way you came in, and try not to mess with any of the crime scene. You can cause some very heated confrontations with this to happen. So this, in some states, EMTs do not have the authority to pronounce a patient dead. Now you might say, well, this patient's futile. We're not doing any resuscitations. But I've seen in Louisiana a lot of times that they would have to bring patients by the ER to have a physician to pronounce them. And I've seen funeral homes do it from nursing homes and things of that matter. In the state of Mississippi, you do in fact have the authority to pronounce somebody dead. A police officer can pronounce somebody dead. They have that in Alabama. I'm not sure. If somebody can provide me with that information, it'd be great to know. But if there's any chance that life exists, the patient can be resuscitated, then you need to do those start resuscitative efforts and transport. But if death's obvious, no urgent reason exists to move the body, then don't move it. And don't allow other people in, and don't give out information outside, because everybody's going to come up and say, hey, what happened here? Usually the actual cause of death can be determined by a medical examiner or physician or coroner. Some states it's called. Death is generally defined as absence of circulatory respiratory functions. Also, some places they go in a little bit deeper and call it brain death, which means there's irreversible cessation of all functions of the brain stem. Their heart might be beating, but they consider their brain to be dead. Physical signs: if the body's warm and intact, need to initiate medical care, with the exception of hypothermia emergencies. If they're underwater or out in the cold, that's fine. If they're cold in a house and it's 80 degrees, then that's probably not hypothermia. Presumptive signs of death are generally adequate, particularly after severe trauma or long-term illnesses. Of course, it's not going to be seen in all cases. So most medical authorities consider presumptive death, for example, if they're brain matter or something like that exposed, or they've got injuries that's not sustainable to life, or blunt force trauma and nothing's been done for 10 minutes. Those kind of things are pretty much considered presumptive. The lack of pulse, no eye movement, no blood pressure, cyanosis, lowered body temperature, those are pretty much presumptive. Hey, I can presume the patient's dead. But when you get decapitation, dependent lividity, or rigor mortis, man, that's definite. That's definite. Put your hand on there, and I'm not going to do that. I'm not going to put my handprint on there. I can do that without it. But obviously, if you do touch that, and the blood exits and doesn't return back, then you can pretty much say, hey, this is very dependent lividity, and this patient is not going to come out of anything I do to him. The medical examiner usually notified I know in Mississippi, any unplanned or unscheduled death, the unknown cause of death, suicide, violent death, poisoning, anything that happened that pretty much was unscheduled. Organ donors, I've never checked for an organ donor card before. I don't, a lot of times they determine that under certain criteria at the hospital. Even if they don't have an organ donor card, I've seen them have to maybe call and see if the family would consider that. Medical identification bracelets, you don't see those as much as they used to, even though there are some out there. And I've seen some that have DNR on them, state of Wisconsin. And they just have do not resuscitate, state of Wisconsin. And they had no name on it or anything like that. I wouldn't use that, because I don't think it's legal there. It doesn't meet our legal criteria. I don't know about Wisconsin, but if it doesn't have any name or identification purposes on it, then I don't see how it could really hold up under anything else. So, but that sums up tonight for us. Does anybody have any questions, comments, or concerns? You got several days off before we have our next class meeting. I'll start my tour of duty starting tomorrow night. Robert, do you have anything? I saw you light up.
No, nothing important.
Okay. All right. The rest of y'all, if you're on duty, be careful out there. If not, y'all have a good few days off, and I look forward to seeing you next time. If some of y'all
we do need a pin.
Do what?
We do need a pin number.
Oh, I'm sorry. You need that pin number. All right. The way I was going to do tonight is the 6th. Let's see. 1, 6. All right, tonight's pin number is 16843. And what that stems from is simply the date and the time that we got finished. 16843. All right.
Appreciate it. Enjoy your week at work, man.
Okay, if any of y'all are on here from Alabama, maybe a couple of things you can find out for me as far as if the EMTs can declare death over there, and just a couple of things we have talked about before, just for general knowledge. Yes, sir.
What was the question again?
Oh, like if EMTs can pronounce somebody dead in Alabama?
No, they cannot. You have to notify on-call medical control.
Okay.
And then they'll advise you, don't resuscitate.
Okay.
And from that point, notify the coroner, and then you have to go to the hospital and get a signature from the doctor.
All right, good deal. Okay, well, I appreciate everybody bearing with me tonight, and through my technical difficulties, I don't know, sometimes it happens. So y'all have a good night, and I'll look forward to seeing you next time.
Have a good one.
All right, man.